Welcome to our third session of the Learning Collective for the Vaccine Delivery Partnership. Today, our session will be on best practices on COVID-19 vaccine confidence and uptake. And we're going to have three speakers today that we're very excited about hearing from. If I could get the next slide. Just to, for those who maybe this is the first call, this is the Learning Collective that was established under the COVID-19 Vaccine Delivery Partnership with the idea to kind of consolidate and share lessons learned and experiences from different countries so that countries can hear what other challenges other neighboring ministries of health may be addressing or struggling with. And it's directed at both anybody basically involved in a COVID-19 vaccine implementation program, and of course, all the partner staff that may support those countries in their implementation. So we're trying to make this very interactive and kind of low key. We have a bunch of polls and question and answer time that is quite liberal. So we look forward to hearing everybody's kind of feedback. Please use the chat. If you have questions, thoughts, reflections, things you want to link back to your own country experience. And if you can, we'd be very grateful if you could type in your country and title in the chat, just so we have a sense of who's on the call. So next. So as I said, this is our third session. The first one, we had the honor of having Sierra Leone, Burkina Faso talking about identifying and vaccinating priority groups. Last month, we had the MOH from Iraq and Ethiopia on integrated immunization services. And today, we will hear from Cameroon and Tanzania. Our August session is canceled. We'll just pause until September because of the holidays. And then we'll move into 3 more sessions closing out the end of the year. And we'll see, maybe we'll pick it up in 2022, but let's see where we all are. So thanks for those who are typing in your names into the chat. Very much welcome. Next. So we'll run through housekeeping. Then we have several distinguished speakers with us. We have Gloria Lehemo from UNICEF. She's a social behavioral change specialist, giving us kind of the big picture on good practices on demand generation interventions and highlights from the global event and providing you some resources. Then we have from Tanzania, Dr. Edwin Mungongo from Health and Care Program, who is the Health and Care Program Manager from Health Age. We have also Dr. Mwenda Eunice Mwenezi from the MOH Tanzania. She's the M&E coordinator. Unfortunately, I think she's in a place with very low bandwidth, so she may not actually be able to speak, although of course she was an integral part of the development of the presentation. And we have Dr. Bernard Ndamgoba, who's the Senior Program Manager, also from Health Age, who will co-present. And I apologize, his name was on the slide before, but it seems to have disappeared. So followed by some question and answers, and then Cameroon will help us close up. We have Dr. Mbianke Livencliffe, who's the Senior Immunization Officer from Value Health Africa, Cameroon, and Dr. Nimbus Albuquerque, who's the focal point for COVID-19 vaccine demand from Limbe District Hospital. And then we'll have a wrap up and closing poll that will be closed up by Santosh. So if I could move to the next slide and invite Santosh to run through this housekeeping. Thanks so much.
Thank you, Diana, and welcome everybody. For those who've joined, I'm just going to walk you through a few housekeeping slides and a quick, very introduction poll. So before we jump into the presentation, can we move to the next slide, please? So we have the interpretation services available. In French is available. And if you click the globe button on your taskbar, you can see that the service is available and you can choose the language you want to listen to. And then if you want to kind of listen to the only interpreted language, you have to mute the original audio. Next, please. We also have the live transcripts function, and you click on the live transcript and you choose, if you want to see the live transcript, you choose the show subtitle. And if you don't want to see it, then you just press the hide subtitle and then you can see the live transcription. Next slide, please. For Q&As, we have the chat functions. Use the chat to post your Q&As, but we would also be pausing after each country presentations where we will take in questions. So feel free to raise your hand and come in and ask a question to the speakers and the presenters. Next, please. This session is being recorded and your attendance is the consent to be recorded. The recordings, the PowerPoint, and all of the resources of this presentation, session 3, I'm going to share the details in my concluding slides and also give you a little bit of insight on the post-session survey and a certificate of attendance that you can obtain at the end of the session. I will talk about it more in the concluding slides. Next slide, please. I use registration, participation, Q&As, chat comments, and poll responses for some ECHO programs. Your personally identified data will be shared with the project funder, and the data may be used for reports, maps, communications, surveys, quality assurance, evaluation, research, and to inform new initiatives. Next, please. Before we jump into the presentations, we have 2 introduction poll questions. So if I may request the team to show the poll question 1. So for the poll question 1, for all the participants, what has been the biggest challenge that you faced in improving the vaccine demand? Is it the lack of trust in vaccinators and health services? Is it misinformation and rumors, vaccine hesitancy, concerns over vaccine safety and efficacy? Is it access issues, difficulty in registration of the vaccination site is far away, transportation costs, etc., or diminished risk perception and prioritization of the COVID-19? Or is it other reasons? All the participants, we'd encourage you to take the poll. I can see there's a 45% is taking the poll questions. I would encourage more. Just give it a few seconds. Yeah, can we end the poll and share the results? Yeah, for the first challenge, I think most of the participants have responded that it's the diminished disease risk perception and prioritization of the COVID-19, where 34% have felt this is the biggest challenge. The second reason being misinformation and rumors, 26%. Lack of trust in the vaccinators and health services is 17%. Access issues, where there is difficulty in the registration of the vaccination site being far away, 11%, and concerns over vaccine safety and efficacy, which is 9%. And 3% have responded that the biggest challenge is vaccine hesitancy. Can we move to the second question? The second question: what's been the biggest success factor that has contributed to the increasing uptake of the COVID-19 vaccination? Here, once again, the responses are community engagement. Is it addressing rumors and misinformation? Political leadership and support, using data to inform interventions, mobilization of influencers, tailored solutions to reach priority populations and vulnerable groups, or is it others? What's been the biggest success factor? %50 have participated in this poll question. We would encourage more participants to respond to this query of the biggest success factor that has contributed to the vaccine, COVID-19 vaccination. Yeah, can we end the poll and share the results? Yes, in terms of the biggest success factor, we can see that it's political leadership and support. But 33% feel that there's the biggest success factor that has contributed to the increased uptake of the COVID-19 vaccination. There is also community engagement, which is 23% of the participants have felt that is the biggest success. 18% have felt that this tailored solution to reach the priority populations and vulnerable group has been the success. And addressing rumors and misinformation, 13%, and 3% have felt that data using data to inform interventions, and also 3% have felt that other reasons that has contributed to the biggest success factor to the increasing of the COVID-19 vaccination. Thank you all for taking part in the poll, and we can stop here, and over to you, Diana. Thank you.
Great, thanks so much, Santosh. So let's go straight into the first presentation. Can I invite Gloria to put on her camera and then go ahead on your slides? Thanks.
Thanks, Diana. Can you hear me?
Perfect.
Oh, excellent. Hello, colleagues, and thank you for the opportunity. And it's good to see some demand colleagues on the call as well. So hopefully you'll also have an opportunity to contribute to the reflections when we get into the Q&A after. So can we move to the next slide, please? Yeah, thanks. So I'm just going to run you through a brief overview of the demand landscape, and then I'll offer some highlights from the recent global demand event that we held in June. And then after that, we'll deep dive into the country examples that will speak to more detailed examples of how the learnings we had from this event is actually informing interventions in the demand space on the ground. If you can move on to the first slide, please. You. So just kicking us off with a little bit of a context. So we know that there's only 58 countries that have actually met the COVID-19 vaccination coverage targets. And few of these countries are actually in the low and middle income countries, where we only estimate that about 30% of people in these low income countries have actually been vaccinated. And then we've seen that also that the challenge for most of the countries is to reach their vaccination targets has evolved from the situation we had at the end of last year, where we know that we had an issue with supplies reaching communities. Now we know that supply has now outstripped demand, but we also are seeing that there are other challenges that are also contributing to some of the low uptake. And some of these include the diminishing risk perception, as we've also seen, is a prominent sort of like factor that you have also alluded to on the polls. And then we've also seen that an adherence to the preventative measures for COVID-19, as well as a lack of prioritization of COVID-19, have also contributed to this challenge of countries meeting the vaccination target. In terms of some of the key barriers that we have seen with regards to uptake and demand promotion includes suboptimal delivery strategies. So which means that we just have not seen some strategies that are really meeting the needs of the communities. In some areas, there's been lack of trust in health systems and authorities, and also in some cases, just an absence of social norms to support widespread uptake. All of this, of course, underscores the urgent need to accelerate COVID-19 vaccine uptake, and at the same time to promote routine vaccination as well as primary health care. Next slide, please. So like I mentioned earlier, we had a global demand event that was commissioned by the Vaccine Delivery Partnership last month, and it convened almost 450 stakeholders from across the globe. And the objective of this event was to discuss proven and promising interventions and practices that are designed to increase vaccine confidence, boosting demand, and generating momentum around COVID-19 vaccination. And we had two sessions pretty much during the event. One was more political high-level dialogue session, and then we had some technical sessions also that speak to key areas of demand, including social and data and evidence and how this informs targeted interventions. We had presentations that speak to service delivery that meets communities where they're at. We had sessions around misinformation, as well as community engagement interventions that are targeted towards vulnerable priority groups. So some of the key highlights that came out of the high level stakeholder panel was the need to, of course, continue to invest in time, resources, and political capital to galvanize government's momentums, especially in light of this reduced prioritization of COVID-19. Along with this, of course, we heard about the efforts to increase overall vaccination coverage, shifting now to more targeted strategies that reach those people who are the most elevated risk. So less of more mass campaign type of interventions and looking at more targeted, tailored strategies. And then the panel also highlighted the importance of mainstreaming and maintaining momentum for political leadership at all levels, whether it's national or subnational, bringing all the partners together. And all of this, of course, speaks to the need for having very clear and consistent, coherent approaches and messaging that address the public concerns. There was also a discussion around the impetus for having a more balanced approach that supports COVID-19 and routine vaccination, while at the same time strengthening systems, health systems and community systems as well. So all of these colleagues who are speaking to the deep dives from their countries will elaborate on these factors with more precision. So if you can go to the next slide. So in terms of some of the most promising interventions that were highlighted during the 4 technical sessions that we had was, of course, the crucial role that trusted individuals and organizations in communities play in reaching the most vulnerable. So at this, with this, of course, we were putting more emphasis on retaining the focus on fostering trust, rather than just having an objective of getting people vaccinating, but putting all the systems in place within the communities to engage them with a view to getting them interested in vaccination as an ultimate goal of our trust building interventions. We also saw that some of the successful demand interventions have really employed a very multi-pronged approach that puts communities at the center. So this speaks to the need for enhanced participation of communities, co-creating solutions with communities, and bringing services closer to where people are. And we also saw some very good examples of innovative solutions for last mile interventions to bridge the equity gap. So of course, we have to bear in mind here that just having an awareness of the vaccination's availability does not always translate into action. We know that many of the priority groups, including the elderly and people in rural communities, may face additional barriers in accessing this vaccination. We also had about tailored strategies that speak to specific needs of, for example, females, and how countries have been able to shift the needle to be able to increase coverage among some of these priority groups. With regards to the efforts around misinformation and addressing concerns, we heard about interventions that have put more emphasis on strengthening existing listening structures and mechanisms to inform RCC actions, and also being very nimble and agile in the way that we harness and get these insights from the communities, and how we use that to translate RCC interventions to actually meet the needs of the communities. And of course, this also speaks to the need to not underestimate the importance of having social data informing our tailored strategies that put people at the center of the approaches that we use. And then just to conclude on some of the approaches that we had, of course, there was a lot of discussions that around the whole issue of the challenges and opportunities that we are presented with in terms of how we integrate COVID-19 into routine immunization and wider PHC. And we discussed a lot of different entry points around outreach, and also trying to understand that for us, in terms of like what we should be looking at in terms of integration, is trying to really understand what the community priorities are and tailoring our integrated approaches to be able to respond to the actual community needs, as opposed to just dovetailing on whatever integration opportunities that are happening. So my colleagues will provide more details with regards to how they've actually implemented these strategies within their specific countries. So we'll hand over to Diana.
Great, thank you so much. I would like to invite the Tanzania team to go ahead and kick off. And if I could ask Dr. Mgongo and Dr. Namgoba to just introduce yourself briefly. Did you want to go back to that slide on the resources, Gloria, or you go back?
Yes, I do. Actually, yeah, I thought it was at the end of the rest of the presentation. So we do have a list of slides that a list of resources that will be shared along with the slides that speak to some of the key resources along the different pillars for vaccine demand and uptake. So you will have access to this. And this also includes the resources from the global vaccine demand event that I was just speaking to earlier. Yeah.
Perfect. Thank you, Gloria. So to the Tanzania team, Karibu, turn it over to you to get started.
Okay. As I introduced myself before, I am Dr. Edwin Mungongo. I am the Health and Care Program Manager here at HelpAge International, Tanzania. I have my colleague with me here. I think he can introduce himself. Well, I think he's having difficulty with, if I may add, our colleague from the Ministry of Health so far has not been able to join us in this meeting. So from the beginning, as I said, she gave me a green light to present on behalf of the ministry in case she does not succeed in joining us. So, as I said, we prepared the presentation together, so I think that is acceptable. Next slide. Yeah, so Tanzania, I'm going to present on a COVID-19 vaccine equity and access for older people in Tanzania. Those most at risk come first everywhere in this country. Next slide. This is where we were as regards full vaccination by countries before June 2022. You can see we had only 4.7%. Next slide, please. Well, Tanzania joined COVAX late in July 2021 after resuming reporting on COVID-19 to WHO. As you know, we had a short period of denial. So the initial focus of the government was on frontline health workers, older people, and those with existing health conditions before covering the general population. There was a low uptake of the vaccine when they were first introduced, with the worsened impact on older people due to various barriers, which included wrong and misleading information on COVID-19 and the vaccination. The government targets to vaccinate about 70% of the population aged 18 years and above, which is 21,518,649. That is by December 2022. But now, a problem, elderly people, despite being in the high-risk group for COVID-19, are still hesitant to and refuse to accept the vaccination. This is due to limited exposure to mainstream media and correct and reliable source of information, limited health-seeking behavior as it is, coupled with a high level of ageism among the communities. So we find the communities don't urge older people to go to accept vaccination. There is misleading information on COVID-19 and the vaccine, at times propagated by high-profile people in the communities, including religious leaders. The government and we other stakeholders have been addressing this issue. Next slide, please. Now, leveraging on existing HelpAge international community led COVID-19 prevention and vaccination approaches. Facilitating, HelpAge has been facilitating older people's associations to lead dialogues from districts to village level. You see, we have older people association from village to council, village, ward, council, regional, and national. So we facilitate older people to lead dialogues, which will result in older people being convinced to accept vaccination. Also mobilizing home-based care, healthcare providers, village health workers, and active aging clubs to disseminate accurate COVID-19 vaccine information. As I said, here you have peer educators who also participate in educating older people, their peers, I mean, that is older people to accept vaccination and supporting. HelpWage has been supporting outreach vaccination programs for the most challenged individuals. Actually, HelpWage supports outreach, we call it streamlined outreach health services for other services as well, where we are implementing projects. This is one of the activities that is supporting outreach health services. Now here we use this to support vaccination. Next slide, please. Now, what are the actions? We facilitate community engagement and dialogue to clear misconception, myths, and rumors on COVID-19 and the vaccine. Adapted intergenerational dialogues to facilitate communities to accept correct and reliable information and create trust among different age groups. Supported outreach COVID-19 vaccine program to remote areas and the most challenged individuals. Directly engaged groups where home-based cares, as I pointed out before, active aging clubs, young volunteers, and government health workers. As it is, we have been, where we implement projects, we have been training, we have been training government health workers on how to provide age-friendly services to older people. Design of community maps to identify older people living with disabilities to create access to vaccine in the most hard to reach rural areas, which requires leveraging on existing community-based monitoring platforms. Conduct monthly home-based surveys to collect data, use of national vaccine data, because this is in the hands of the government. Next slide, please. Now, with the support of UNICEF in the initial 3 months of intervention in the 2 selected pilot regions of Mwanza and Kigoma, resulted in 99% increase in COVID vaccination in older people and 88% in other age groups. As it is, as I pointed out earlier, that the government started with older people, frontline health workers, and those with underlying health conditions. Later on, the vaccination was extended to other age groups. Later on, 5 program regions, Kigoma, Mwanza, Njombe, Simiyu, and Tanga, covering about 600 village communities with HelpWage intervention in collaboration with the government. The number of people vaccinated increased from 7,830 in February 2022 to 18,469. That is 40% in May 2022. And the people with disabilities from 1,670 to 2,792. That is 25%. The regions emerged from the least performing to first regions in the vaccine uptake. The achievement in the 2 pilot regions attracted the interest of the central government, because in those districts, we are working with the local government. So this attracted the interest of the central government leaders and some key stakeholders for targeting older people as key vaccine beneficiaries and advocacy campaigns. Community intergenerational dialogues resulted in increased confidence and courage on the vaccine and allayed misconception, rumors, and myths on COVID-19 and vaccine across different age groups. Sorry, something is blocking my peer-to-peer awareness is come on. Excuse me, this peer project. In communities about the COVID-19, the availability of home-based care providers, active aging clubs, and youth volunteers to disseminate correct COVID-19 information, created an open forum for further bi-directional intergenerational engagement to address issues such as ageism and sexual and reproductive health services as multiplier effects. Outreach vaccination programs is key in addressing vaccine equity and access for most challenged individuals, particularly older people, people with chronic illness, and people with disabilities in most of the rural areas and hard-to-reach areas. The community dialogue and outreach services approaches can be easily applied in another context in clearing misconception, rumors, and creating confidence among groups, but also in reaching the most challenged groups, individuals in remote and rural settings. Next slide, please. Next slide. Now, as regards these slides which were to be presented by the government, I think with your permission, I will present them. How the intervention has impacted coverage and plans to take it to scale up parts of the country and what other countries can learn from this intervention. After joining COVAX in July 2021, due to fewer doses of COVID-19 vaccine received initially, the government prioritized frontline health workers, older people, and those with prevailing health condition to start receiving the vaccine. As it is, these are the most at-risk group of people. The government invited other stakeholders to complement its efforts in a campaign to convince people to accept vaccination. The result was positive. In areas where stakeholders, including HelpWage included, were engaged in advocating for the COVID-19 vaccination, the number of people accepting to be vaccinated increased appreciably. Later, the government adopted the outreach COVID-19 vaccination services for older people living far from static health facilities all over the country. The approach had been in use in HelpWage Project Dixie since 2018. As I said, we have been using the outreach to provide health services to older people. You know, we have outreach, but usually the government uses them for pregnant mothers and under 5 children. But HelpWage has been using this approach to provide the age-friendly services to older people who are living in rural areas and hard-to-reach areas. So the government also adopted this approach. After more vaccine doses were made available, the government later included people in all other age groups in the COVID-19 vaccination and increased the number of facilities providing the COVID-19 service nationwide, because initially only 500 were selected when the vaccination program began, but now all over the country, all health facilities are providing the vaccination. The government has continued with its campaign for COVID vaccination to date. The number of vaccines has continued to rise. Next slide, please. As of July 13th, July 2022, the number of fully vaccinated people who are 18 years and above was 10,377,341, which is 34% of the population aged 18 and above. So who are the population age 18 years and above are 30,740,928. Out of this, the number of vaccination older people was 782,143, which is 30% of the total number of older people. That is 2.6 of the population. This is according to our population census of 2012. The government continues ensuring the availability of COVID-19 vaccine. The government has learned that alone, it cannot attain appreciable achievements, including other stakeholders, has contributed, significantly to the achievement attained. HelpWage International is commended for its efforts in this endeavor. Outreach health services, including COVID-19 vaccination, is key to achieving high coverage. This is because most of the older people live in the rural areas where health services are not readily available. Next slide. I just want to say thank you to you for listening.
Thank you so much, Dr. Ngongo. Extraordinary achievement to get to 34% coverage just in the past few months, and particularly a really excellent description of the type of interventions to reach those who are in the older age group. And I hear Robert Kanwagi saying thank you for the great work. I think I echo that, as many people on the call do. So we have about 15 minutes just for some back and forth, questions, dialogue. So can I just invite and everybody's speakers, you should be able to unmute yourself. So anybody who has questions or reflections, please feel free to raise your hand, or if you prefer to type it in the chat, and we'll take the questions as they come in. I think we have a number of different countries on the call, from both the east side of Africa, but also the west side. We have Nigeria and Sierra Leone. I think we had Madagascar, I saw, has joined. So anybody, please feel free. Thank you, Bretta, very much for the reflections. So while people are gathering their thoughts, I did have a couple of questions already to both speakers. To Gloria, I actually have three, sorry. So I have three questions. One was to those on the call. So people said the biggest challenges are the diminished disease perception and the misinformation and rumors. So I would love to hear from those working with countries, kind of what you can type it in the chat or jump in, kind of what strategies are countries using to deal with that. Or maybe it's just one of these intractable problems that is difficult to deal with. That's one. Second was for Gloria, you know, it speaks often about misinformation and rumors and kind of interventions that are needed for that. But misinformation and rumors is often about things that are not true or partly true. But there are clearly some adverse events that happen with vaccination, and people know that, and there are public concerns with that. So they're actually real events that happen. They're quite rare. But I think it also feeds into people's fears, right, about getting vaccinated. So I just wanted any kind of reflections you might have of not specifically dealing with misinformation, disinformation, or rumors, but addressing people's legitimate concerns or anxiety of safety. That's one. The second I had for Dr. Ngongo and the Tanzania team is just, could you speak a little bit about this intergenerational dialogue? How does that work? It actually sounds extremely interesting. It's the first time I've heard about it. Maybe it works even beyond in COVID-19. So just to hear what Tanzania does with respect to intergenerational dialogue and how does that work? Thank you. And I don't see any comments yet in the chat or questions, so we'll just let you guys answer those and then open up the floor again. Thanks. So Gloria, you want to come in first?
Yeah, sure. Thanks, Diana, for that. I mean, just to start, and I'm glad you raised that whole issue of how misinformation and rumors are often construed to be sort of like the main concern with regards to vaccine uptake. And just to clarify that I mean, of course, while there has been an infodemic that is contributing to low uptake, it's just one part of like a wide range of barriers that we see along the spectrum of vaccine uptake. And yeah, and I think the best examples that can speak to the fact that just understanding people's genuine concerns with regards to this safety, efficacy, and whatever other concerns they might have with regards to the vaccine are legitimate concerns. And for example, one of the areas where we've had data that has spoken to this was in both Sudan, South Sudan and Sudan as well, where we had incidents of low coverage among females. And when data was conducted with focus group discussions and other sort of like analysis and misinformation sort of listening, the understanding was just that the females generally had genuine concerns about issues that they thought were linked to fertility of the vaccines. And the minute you understand what the legitimate concerns are and you tailor your communications around addressing these issues, then obviously that goes a long way in terms of like building confidence in the vaccine itself. And also we even have evidence that speaks to how this was able to contribute to an increase in coverage among this particular demographic. So people do have genuine concerns, and it also underscores the importance of having like very, very nimble and very sort of like real-time listening mechanisms that are not just online, but offline as well. And that we're able to tap into trusted sources within the communities that can be able to respond to people's concerns from sources that they actually really trust. And I think maybe just to kick off the other discussion with regards to diminished risk perception, I think it's also important to underscore the fact that even though there has been a diminished prioritization, what we're seeing is that people will want to get vaccinated if it's available, convenient, and accessible to them. So it'll be interesting to hear from colleagues who are implementing on the ground how they are able to still get people to get vaccinated despite this diminished risk, just by making vaccines accessible to people where they're able to reach them. Yeah, over.
Super, very helpful. Thank you, Gloria. Dr. Ngobo, because it's you going to maybe respond a little bit on intergenerational dialogue. There's also 2 questions in the chat, which I will read to you, so you can also answer those.
Sorry, am I unmuted? Because it seems you have to unmute me. Can you hear me?
Yes, we hear you very well.
Well, I will respond on the first one, on the intergenerational dialogue. For sure, this is one of the approach which we feel has given us all the results we have achieved. You know, dialogue is, of course, we all know dialogue is beyond campaigns. This approach gave us opportunities to bring together community members to reflect on different myths, their beliefs, and whatever. Remember, in most of our cultures in Tanzania, each community had their own myths depending on their culture. So for us to be able to break through these myths, we had to go beyond campaigns, instead bring together all sections of the community to reflect on those which of course are compounded by their culture. So in our intergenerational dialogue, we capitalized on older people as lead people in our community. You know, older people in our communities, most of the time they are lead. So they were leading this community dialogue where all different generations, youth, women, older people were coming together, plus these other influential people in their communities to reflect on the issues. And the advantage of these dialogues were all this generation could bring in their different perspective. Remember, older people have limited exposure to media, but we have youth who have exposure to media, and sometimes they are distorting some of this information. So bringing them together to reflect on these issues, question each other, and at the end of the day, reach consensus of how they are going to address issues at the community level. Remember, after this international dialogue, going forward, we are to implement community-drawn campaign. So from this dialogue, the intergenerational dialogue, where these different generations were coming together, at the end of a session, there was a plan which we are drawn now to go around in the communities and address these myths. Now, the program we are supporting these campaigns going forward. But initially, this was like a breakthrough where we were able to note what are the challenges in all the generations and how we could address using our own resources and using our own efforts. So for sure, this dialogue were very key. And probably in addition, there are also educative sessions where youth would educate other people on what is going on, and other people will tell youth what they used to see in those years. So for sure, these were key interventions as open up for campaigns going forward.
That's super. Thanks so much, Dr. Ngobo. I'm looking at a few reflections in the chat. So while your mic is still live, I'll just ask. The question was, were there specific, from Amy Groom, are there specific vaccine safety concerns among the elderly that is different than the general population? And a second question from Jacob Matianga about what key lessons or takeaways have you learned from the interventions? And I think you've just said the intergenerational discussions were incredibly important and key. But can you come in on that?
Yeah, probably I would address, I don't know, the key lessons. I think we have seen the first one, which is the intergenerational dialogue. For me, it's a key lesson because, we have to understand that in Africa, health-seeking behavior is an issue. And the health-seeking behavior in Africa is not only about people going for screening, but it's also about preventive measures. And remember, COVID vaccine was like a preventive measure. So in Africa, people are not interested in preventive measures. They would go for curative services and not much on preventive measures. So taking a vaccine promotion program is just a campaign issue was an issue. And I was very impressed when UNICEF included this in their, the behavioral change, because it's also about behavioral change. And as I said, intergenerational dialogue were part of it because it was addressing both the health-seeking behavior and again, for people to reflect on that, and again, the campaigns on the other part. The other lesson for us was, bringing these generations together is helping so much to ensure when these issues are discussed at community level, they are clearly accepted and understood, because there is nobody who will be there to champion the other side. So that is one. But again, the peer-to-peer, I think Dr. Edwin has presented it quite very well. The peer-to-peer engagement, where these dialogues were allowing now other people to engage their peer, youth to engage their peer, women to engage their peer. At the end of the day, they are coming together at a campaign where at least each peer is engaged the peer. So for us, the peer-to-peer and then bringing together as a community to campaign was one of the key lessons. But again, using other people as lead, because these, as I said earlier, they have a role in the community as leaders, as advisors. So using them to break through the myths and rumors were key in addressing all the rumors and misinformation. The other one was about the package for other people. For sure, there was no specific package for other people. Vaccination was for all. So what we were doing was to ensure other people are reached. Dr. Edwin was talking about outreach programs. As such, it is not just about going in the most remote rural. It was about going in the most rural player to mobilize other people and ensure they accept. Then they are mobilized at the center, then is where now you go. Because otherwise you'll go in the most remote rural and these people are not prepared, you just get 2 or 3 people for the vaccine. So it was about going first, mobilizing, engaging, and then mobilizing them at the center. Then you now go with the vaccination team to do the vaccine to those groups. So yeah.
Great. That's really such helpful characterization of what's happened and this importance of kind of linking the peers with each other. I wholeheartedly agree that people are mobilized by, you know, what they're, those that they respect and they're closest to. And you had your hand up for a while. Did you want to come in? But then you took it down.
Yes, I put my question in the chat actually, because I saw health age, and I wanted to know, of all the other countries that are connected today, how many of you are actually connected to NGOs, organizations that are tailored specifically to the elderly? We have worked with the International Federation of the Aging. And have you then all linked up with all possible kind of the right CSO NGO style that people that have this deep knowledge, as you've just explained from Tanzania, of how to use and work through the elderly here? Thank you. If anyone else wants to share also of participants.
Yeah, so if anybody wants to jump in on that, we have about 2-3 more minutes for discussion before we move to the Cameroon presentation. Thank you so much for those who have been putting in lots of things in the chat. A plug here for the youth engagement subgroup of the collective service to kind of try to engage youth, which looks like a super interesting initiative. With some details provided by Teresa to take a look. And as the last shatter Robert Kanwagi put in, which makes a lot of sense, is this importance of kind of helping the young people to kind of transmit the information to their elders, because they obviously have more access to social media and maybe more knowledge. Certainly is the case in my case with my son, who often tells me things I don't know. I think that's really true in this current age, with the social media and information moving so fast. You often have the younger generation who are a bit more access to that. We just had one last question, I think, that I wasn't able to run into from our Cameroonian colleague, about whether the data, Dr. Livincliffe, whether the data that was being presented by Dr. Ngongo is that specific to the districts where help age worked, or were those statistics being cited were national statistics? If you could just clarify that.
Yeah, well, these are national statistics. Of course, what we are doing to connect to what one of the participants has asked, HelpAge International is working in collaboration with CSO partners at common level. Remember, aging is not an area where many organizations are interested. If you look in Tanzania, we are only an international organization which is working on other people, but of course, coordinating with these other NGOs to address aging issues. Now, for us, we are as well coordinating with aging organizations, CSOs at common level. So we have 2 ways of getting data. First of all, we are getting data from our other people associations at these levels, at all the levels, basically from village level to national level. We are compiling these here at the headquarters. But because we are not allowed by law to publicize our data, we are trying to coordinate with now the ministry to harmonize our data. Of course, there are always differences here and there, but at the end of the day, we have to publicize the data we are getting from the Ministry of Health. So for sure, the data we have presented today are the data which we have harmonized with the Ministry of Health, and we have been able to publicize them. It is unfortunate that there are challenges here and there, and Last week we had a UN delegate visiting Tanzania. We had the same challenge on the data, but of course, we are trying our level best to try to ensure we are harmonizing this information. So we have information from our areas where we're implementing, but countrywide, we have data also which we are getting from our other people association at community level. At the end of the day, we are compiling all those together and then harmonizing them with the Ministry of Health. And we are member of the National RCC.
Great, thank you for the very thorough reply. Yeah, I think triangulating data is a challenge for every single country, particularly with the speed team and the changing denominators and target groups. So I'm sure you're not alone in that initiative. So great. There was one question in the chat on AFIs. If you know that answer, I just invite you to just type the answer in the chat. We're going to have to move on to the next group of speakers. So can I just invite, first thank Tanzania very, very much for a great presentation, very stimulating, and move it on to the Cameroon team. Dr. Livingcliff or Dr. Abturki? Yeah, great.
Yes, I'm here. Okay, thank you very much. Good day, ladies and gentlemen, wherever you are located in the globe. I'm Dr. Bianca Livingcliff, Senior Immunization Officer for Value in Africa, Cameroon. And today, together with my colleague, Dr. Gembus Jackie, who is the focal point for COVID-19 vaccine demand and the head of the cholera unit in the Limbi District Hospital. So today we'll be sharing our experience and our work on community engagement and vaccine confidence building using integrated routine immunization tools. Next slide, please. Okay, so this is the first slide is just an introduction of myself and my co-presenter. Next slide. Okay, so before our intervention, we did an analysis of the COVID-19 vaccination coverage within the specific districts that we located for the intervention. I must say we carry out these interventions in 10 health districts, 5 in the southwest region of Cameroon and 5 in the northwest region of Cameroon, which are the conflict zones in Cameroon. So we focus our intervention within the conflict areas of Cameroon. So, but today I'll be presenting. The results from these two districts. So by December 2021, less than 2% of Cameroonians were fully vaccinated against COVID-19. And the Anglophone region of the country had the poorest rate of COVID-19 vaccination coverage, like spread out here. We have 0.7% in the Northwest region, as well as we had 0.9% in the Southwest region. And factors such as the ongoing armed conflicts have greatly affected the COVID-19 vaccination coverage within these regions. So what did Value in Africa did? Value in Africa supported government's goal to vaccinate about 50% of the population by January 2023. And in such, we tend to understand, we try to find out what are the reasons of the poor vaccination coverage and what are the various strategies we can do to improve community engagement and vaccine confidence within these communities. So Value in Africa carry out several interventions, but the prime of our intervention is how do we use already existing routine immunization tools to boost COVID-19 vaccine confidence and community engagement within our selected communities. And also we use the spectrum of integration to see how we can integrate both routine immunization and COVID-19. Next slide, please. So what did Value Health Africa do to improve COVID-19 vaccination coverage within the selected districts? First, we used routine immunization tools such as the human-centered design approach and the Z-Drop tool. The Z-Drop tool, it simply stands for Zero Dose Reduction Operational Plan. So we integrated these key tools in COVID-19 vaccine. These tools are used for assessing COVID, routine immunization needs, and also assessing routine immunization demand within communities. So we adapted these tools into COVID-19 vaccine demand, thereby assessing how communities are engaged in COVID-19 planning, COVID-19 implementation, and what are the various needs per communities, and what are the sources of information within these communities according to the different groups. So what do? We use KII interviews to understand the perceptions, the attitudes across different groups, such as the caregivers, community leaders, health providers, religious leaders, and also within among people with comorbidities such as diabetes, hypertension, other cardiovascular diseases. So we get an information and about the perceptions of these people within the various groups to understand what they think about COVID-19 vaccine and what is the reason of their disengagement in the planning and the implementation of COVID-19 vaccine activities, especially in demand generation. So the next strategy we did was we organized community dialogue structures, and these dialogue structures were separated into two groups. The youths, the elderly were separated among the male elderly and the female elderly, and also those diabetic clubs, those with comorbidities. So within these dialogue structures, key COVID-19 informations were circulated, and also interviews were carried out within these dialogue structures to understand what people think about COVID-19 vaccine, and also understand the number of people in this dialogue structure that are vaccinated, and the reasons for their vaccination or the reasons for their non-vaccination. And we also use what we call a vaccine confidence meter tool to assess what is their level of confidence when they get into the dialogue structure, and also what is the level of confidence after a series of discussions within their dialogue structure. So we did what we call a pre-assessment and a post-assessment. And with this pre-assessment, we asked various questions about COVID-19, questions such as what they think, questions such as are they vaccinated or not, reasons why they are not vaccinated, do they think they will be vaccinated, and what will change, what will need to change if they have to be vaccinated. And we chatted these questions, and we had a color chart from green, yellow, and red. Green signified that they are confident about vaccine and they are more knowledgeable about COVID-19 vaccines, and also they have plans of vaccinating in the near future. Red signifies that respondents are doubtful about COVID-19 vaccines. They don't know much about COVID-19 vaccines, and they have not yet made up their mind to be vaccinated. While red signifies that respondents are hesitant and they don't want to get vaccinated. So then after a series of community sessions within the various members of the population, we did what we call a post-confidence metal assessment, where those who had first of all taken the pre-assessment were later reassessed and reclassified into the various categories that we have identified here. So now, after getting this source of information, we did a very strategic communication. How do we communicate to the specific groups, such as the elderly, the youth, those with comorbidities, and those with disabilities? So we developed targeted behavioral change messages to each specific group. So that we wanted to make sure that we reach every group with your specific need and with your specific communication. So how do we measure what we did? The first thing we did was we did an assessment of all the community dialogue structures using the post-assessment confidence meter tool to know the number of persons who were first of all hesitant or who were first of all doubtful about COVID-19 vaccine, but who later now had a change of mind or change of perceptions and had vaccine and were confident about COVID-19 vaccines and were ready to vaccinate. So our assessment, our post-assessment gave us an idea about the number of persons who left the yellow or the red mark, perhaps to the green mark, or who left the red mark to perhaps the yellow to the green mark. And also reports from COVID-19 delivery centers gave us an idea of the number of persons from the dialogue structures who later appeared in the COVID-19 vaccine service delivery centers to be vaccinated. So Valiant Africa issued participants in the dialogue structures with referral forms. So we collected a number of referral forms from these delivery centers to give us an idea the number of persons who were first of all hesitant and who later built confidence and now got vaccinated. And also we also analyzed the data from the district to see the progression of the COVID-19 vaccination coverage from December 2021 to June 2022. Next slide, please. Okay, so what are the key outcomes? Like you can, from the illustration here, you can see the progression from December 2021 to April 2022. We have in the Southwest, we had a 0.8% coverage in December 2021. But when we did our analysis in April 2022, it had grew to 3.9% for the Southwest region. And for the Northwest region, we had a 0.67% in December 2021. And in April 2022, we had an increase to 9.1%. So we say there's a steep increase in the number of people vaccinated per day since launching our community engagement strategy in January 2022. So what are the key learnings? What are the key learnings we had while we carry out this approach? The greatest success factor was allowing people to share what they think. Before, we realized that the government strategy was provider to consumer. Communities were not really engaged in the planning and the implementing and the monitoring of COVID-19 activities. So it was more of a provider to consumer affair. But we realized that giving communities the power to design their strategies they feel confident in improves vaccination coverage. And also treating each community as an individual context, because we realized that the sources of information were different, the sources of misinformation and rumors were all different, and what persists within communities differs. So treating each community as an individual context and tailoring communication per community yield a lot of results for us. And we also find out that integrating other tools such as the HCG and the micro planning had big success in understanding the community needs in COVID-19 vaccine. Also, we realized that people with comorbidities such as diabetes, hypertension, and other cardiovascular diseases who had an increased perceived risks were more likely to get vaccinated than those who had less perceived risks when it comes to COVID-19. And also we saw that vaccine mistrust and hesitancy was highly prevalent among the younger generation whose source of information were mainly social media sources. Next slide, please. Okay, so this is just a graphical presentation of the COVID-19 vaccine coverage in December. If you can see, you will see December, April, and June 2022, how the COVID-19 progression within these districts were achieved. So you can see where we were at in December 2021. You can see where we were at December, it's the 22nd April 2022, and where we are now in June 2022. Next slide. Okay, so I will call on my co-presenter, Dr. Gembus, to give us the statistics and how this approach helped vaccination, COVID vaccine coverage within the district. Over to you, Dr. Gembus. Then I will come again at the end.
Okay, thank you for your colleague, Dr. Levan Clive. Working in partnership with Valued Africa, the community health organization actually came into conclusion that the consumer approach was much more better off. That's actually getting the idea and the opinions of the consumers of the vaccines of COVID-19 would be much more better off than actually the government just providing an implementation to the consumers. With that approach, he rightly said that there was a switch of strategy from provider to consumer to provider. The number of persons fully vaccinated in the district was on a rise from about 4,300 in number, that is in December 2021, as rightly represented by the graph, to 20,450 in June 2022. That gave us an incidence of 1.72% to 8.18%. So, however, the vaccine demand at the vaccination side grew from an average of 2.1% per day to an average of 5.8% per day in the district. Well, we are actually hoping that we can achieve a 50% coverage of vaccination of our population by April 2023 if we adopt this approach within the health districts. So what do we actually learn from this strategy? After presenting this idea to the regional task force of COVID-19, the region seems to actually prioritize a scale up in different health districts. And at the moment, our district is in consultation with managers of other districts to assist the planning and the implementations in their respective districts. With this, I will give back the floor to Dr. Levan Clive to continue the presentation. Thank you very much.
All right, thank you, Dr. Ngembus, for that statistics from the MOH. And just to add to what Dr. Ngembus is saying, we have seen a significant increase across the districts that we have worked with. And currently, where the district, the Limbe district is in discussion with other districts within the region to see how they can scale up these projects in this approach in other districts. And currently, Valued Africa is in Madagascar, supporting the government in testing this approach and also to execute this approach within communities and health districts in this country. And we must say that this is an approach that is adaptable, and countries can really adapt this approach per your context, understanding your individual context and seeing how they can engage communities in the designing, implementation, and the monitoring of COVID-19 vaccines will yield a lot of results, and also will make us understand what are the community-specific needs and what are the different shifts that have to be done in order for us to build confidence within communities and also improve in COVID-19 vaccination coverage. Next slide. So we want to thank you very much for listening, and we look forward welcoming your questions and also your insights from what you think in our approach and our presentation. Thank you very much.
Thank you both, Dr. Livencliffe and Dr. Ngembus, for a really passionate presentation. I really enjoyed that very much. So can I just, we have about a little less than 10 minutes just to chat a bit. If anybody in the previous session had typed something in the chat and wanted to raise it again, or if there are new questions to the Cameroon team, can I invite people to step in or type it in the chat. And while people are thinking of their question, I had one myself, which was, so this is interesting, this confidence meter tool. I've not heard that term before either. And this idea of, you know, consumer-driven approach, which is really great. I mean, that's a really great idea. So I would just ask, do you have any specific, it said on one of your slides that then the client kind of in response gets to design what they want, or what would make it or facilitate their getting vaccinated. If you could maybe speak on a specific idea that might have come from the community that you hadn't actually thought of before the government to address, that would be great. And then I see there's another question, and I apologize if I don't say your name right. Wendemagen. So one of the challenges raised was security issues, and maybe could you speak to that a bit? And the last question from Deepa, if you've seen any increase in engagement by the community in the micro planning. So I'll hand it back to you.
Thank you very much, Diana. So I will take over first your question. Yes, we have several responses from concern, because the first, like the outstanding response from the community was I don't know if you're aware with the political situation in Cameroon, but there has been an ongoing conflict, and the population has had great distrust in government structures. So one recommendation by the population was, before COVID-19 delivery services were done just by public health facilities, and most communities felt they were not safe or insecure going to government health structures because of the political crisis. So one of the recommendations they gave was, if private institutions could be involved in COVID vaccine delivery. And that was one of our suggestions that were made known to the district medical officer and also the regional delegate, and that was looked upon, and private facilities also were included, were integrated in COVID-19 vaccine delivery. And that really improved the attendance by the population because of the current crisis. And another thing also that happened that they brought out was also the strategy, because at first it was just the service providers who just in a one fixed position to vaccinate. So the communities, individuals from the communities have to leave, some have to travel long distances to go to the nearby health facilities to get vaccinated. So there was a fixed strategy, and that strategy wasn't working at all, because a lot of people were having complaints of distance to cover to get to the nearest vaccination center. So they had to propose a change in approach, more mobile strategies to hard to reach communities was proposed, and also the strategy was adopted and used, and that also encouraged vaccine coverage within the community. So those are some of the questions that and solutions that the communities brought up, and that was adopted and executed and yielded very, very good results. So to answer, I think I will go to the next question about security. Yeah, security was a very big challenge. I think the person might have an understanding with what is happening currently in Cameroon, and that has been the greatest challenge in ensuring that both the vaccinators and our staff, the project implementers, and also the communities themselves are safe during this period. I remember during the intervention period, we had a series of lockdowns, ghost towns, and I remember our team was caught in one time in confrontations with the military and the separatist fighters. So it was a very big challenge. So, but what we do is we always had a security briefing before we descended to the terrain. We had our team briefed with the security, and there were times we did a lot of collaborations with the separatist fighters, because they were the ones who ensured most of the security. So I personally, I had to meet several of the separatist fighters, discuss with them the importance of the activity and the importance of what we have to do for the community, and ensuring that we are apolitical, we are non-governmental, we are a community-based organization trying to save lives. And most of them, they gave us the accord. And I remember in most times they were the one who even went and encourage the community to participate. Yeah, and that really, really helped us a lot. So that is how we navigated the security concerns. And also to answer Deepa's questions about community engagement with micro planning, yes, and this was a very good strategy, because we realized that even within routine immunization, there were some health facilities who do not understand much about the micro planning. So we did a capacity building for health facility managers on micro planning and how they can engage their communities in carrying out this micro planning within their health facility. And since then, we did, with our monitoring and evaluation strategy, more and more health facilities have been engaged in carrying out this micro planning, not only for the COVID-19, but also it has improved in routine immunization as well. And right now we are trying to also showcase that routine, they can be great use, or there will be great success if we can integrate routine immunization with COVID-19. Because right now you have health facilities who are already dealing